Good morning or good afternoon. I am Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Philips and Sachs Communications, we want to thank all of our frontline workers in our audience for your continued commitment in helping all of us through this pandemic. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time permits. If you do experience technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. If you have any trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Please make sure you're not behind a firewall, as that will prevent you from seeing and participating in this webinar. Our moderator today is Lexi Caraway. Lexi Caraway is currently a senior patient trainer for Hillrom and the former manager of respiratory at Sarah Bush Lincoln Health Center in Mattoon, Illinois. She is a contributing author of a recently published study entitled Prevalence of Burnout Among Respiratory Therapists Among the COVID-19 Pandemic. Lexi has published several abstracts at AARC Congress, including a study on thermographic imaging to detect and prevent pressure injuries. She has presented at several local and state respiratory care conferences. Welcome, Lexi.
Good morning. Thank you, Monica, for that very kind introduction. The title of today's webinar is Saving Face, Respiratory Device-Related Pressure Injury Prevention. We are excited to have two experts in this very critical area, Denise Lauterbaugh and Vicki Haugen. Vicki Haugen is currently a nurse consultant in Boothbay, Maine. Prior to her current role, Ms. Haugen was clinical nurse leader, wound, ostomy, and continence nurse at Fairview South Hospital in Edina, Minnesota. She has been a board-certified wound ostomy and continence nurse since 1989 and is certified in oncology nursing and faith community nursing. Her years of experience include regional and national speaking, litigation consulting, research in her areas of specialty, and publishing in peer-reviewed journals. Denise Lauterbaugh is a clinical practice specialist respiratory at Rady Children's Hospital in San Diego, California. Ms. Lauterbaugh has expertise in clinical practice, consultation, education, evidence-based practice, research, and quality improvement with a focus on optimal patient outcomes and dissemination of information to teams. Ms. Lauterbaugh serves as a pressure injury subject matter expert with solutions for patient safety. She has published extensively on a range of respiratory topics with a special focus on pressure ulcers associated with respiratory devices. Ms. Lauterbaugh has presented at several national and international conferences. The speakers have disclosed no conflicts associated with this presentation. This educational activity is approved for 1 contact hour for nurses and respiratory therapists. A link to obtain credit will be available at the end of the webinar. Support for this educational activity has been provided by Philips. At this time, I would like to turn the presentation over to Ms. Vicki Haugen.
Welcome, everybody. My job today is to get us all up to speed on pressure injury in general. We're going to look at some definitions and things. I'm of interest to note, having done this kind of work for 30 years, we used to think a pressure injury came from someone who was in a facility that didn't take very good care of them for 2 or 3 weeks at a time. We now know with research in surgical areas that pressure injury can happen in as soon as 3 hours. So today our objectives are to define pressure injury, causes and stages, and to discuss types of skin injury and prevention tips. Let's start talking a little bit about some definition. The old standard definition of too much pressure for too long over a bony prominence still works. although we've learned a lot more about pressure now. For example, we know on our larger persons, the bariatric patients, sometimes the pressure injury occurs over, say, the gluteal mound rather than a bony prominence. We've also learned that there's many pressure injuries related to medical devices, which is what our primary speaker today will talk about, related to pressure injuries and respiratory devices. I grabbed this slide to remind us that we used to think pressure injury always happened from the top down. We would get pressure, we'd lose the epidermis, the dermis, that would continue down into the layers, adipose, muscle, bone, and tendon. We now know that there are deep tissue injuries that begin at the muscular layer and open from that layer up. So the cells of the muscle actually are affected first, and we'll talk a little bit more about that in just a second. When we get to stage 1 pressure injury, we're really talking about an area that is still intact skin. The old definition of non-blanchable erythema works on a Caucasian patient. If you press on a reddened area and it doesn't turn white for a few seconds, you have a stage 1 pressure injury. That doesn't work with anybody with skin of any other color, so we have to be really attuned into looking at changes in skin, character, and color related to the skin around it. The picture on the left is a great picture of an erythemic area with a fairly demarcated or even border, pretty traditional for a stage 1 pressure injury. On the right side of your slide, that very well may be from pressure, but you can see the kind of white tissue in the gluteal fold. There may be other contributing factors here, such as maceration. So history about the patient is very important when you're making a pressure injury stage diagnosis. When we get to stage 2, we're looking at loss of the epidermis. So it's like when a kid falls and skids their knee. This is a great picture of epidermal loss. However, it's also, again here, I would say this is not a very demarcated border. There's a lot of sloughing going around of the tissue on the edge. So it's very possible this could be related to shear and friction or moisture. And again, history is real important in making our decision. In stage 3, we have a nice clean ulcer here on the occiput of a young child, which is a common place for occipital ulcers. We now have both the dermis gone, and we're in the clean dermis, or we're into fatty tissue, adipose tissue. But if you see what you think is a stage 3, but there's too much yellow slough or gray slough or any kind of non-viable tissue, that kind of hard shoe leather eschar, then you really can't make that determination. We'll talk about the other definition, but this here is a good example of a stage 3. And stage 4, and this is likely related to a tight respiratory mask, is when you get down to muscle, bone, and tendon, which you can see in here clearly there is some kind of tendon or muscle being shown. That is stage 4. And then this is a very good picture here of what we may call deep tissue injury on this baby. There's a very demarcated, very purple looking area. When you have that kind of very intense hue of purple, blue, or even very intense red, that's often what we call suspected deep tissue injury, because we really don't know. But that's where I talked about the tissue injury itself may open from the bottom up. So you see nothing really open at the top, and then you have a very deep opening ulcer very fast. And again, stages of ulcers, if you can't see the ulcer bed and it's covered with any kind of non-viable tissue, then that's an unstageable pressure ulcer. So what can we say about prevention? Well, there's nothing more important than assessment. Anytime you get a client into your care, your facility, a head-to-toe skin inspection is so important. We know that you need to repeat that every 8 to 12 hours. So we just talked about pressure injury can happen in as little as 3 hours. So important to everybody is to do an assessment. Some of my sister hospitals are doing assessments on bariatric patients with 2 nurses, easier for the patient, easier for the nurses, and a much better skin assessment. And then most facilities do some kind of a risk scale, usually the Braden scale for adults and the Braden QD for preemies and children. The next slide, we're going to talk a little bit about prevention, because you could do a whole lecture on prevention. But remember, the biggest issue here is offload the pressure. So whether that's turning a patient, getting their heels off the bed, putting them on an air mattress, changing where we'll get to devices, but where devices are causing pressure. So all of that is really focused on getting that pressure off and how frequently you need to do that. That's very individual for clients. We know some people can be turned every 2 hours and that's sufficient. We know other people that's not enough time, and they end up very much still having pressure injury happen there. And I can't say enough about education. If you can help get the patient or the patient's family on board as part of your team, and they can say, by the way, I don't think my mom's been turned for a couple hours. Do you have time to do that? When they're part of the team, pressure injury and prevention happen a lot better, and everybody has a better outcome. Device-related pressure injury is just what that is. Some kind of medical device has caused pressure on the skin enough to injure it. The reason I picked this photo here is if there really is pressure damage everywhere that bandage goes, on the heel and along the edges of the leg, that's more likely to have happened from a brace or a boot. And we see that a lot of times, that we don't see either an ill-fitting brace or when we take off the brace because it's been on for too long. So we need to be very vigilant, I think, about looking at all kinds of different devices for pressure injury. The thing that once on a patient, they may have taken wonderful care of them in every other way, but they didn't take down their thigh-high elastic socks. So when the patient came back to us just 3 days later, the nurses called me up. They took down the thigh-high elastic socks, and there was a very deep wound opening up on the patient's anterior thigh. In 2 days, that became a 15 by 4 centimeter full thickness wound, and that was all just from those elastic socks. When we get to respiratory, our primary speaker will focus on this, but I need to just say nurses need to partner with respiratory therapists. We get that the airway is first. A patent airway is a lot more important than the skin, but then we have to look at all of that together. And I know nurses that are uncomfortable with respiratory device care, and being able to be at the bedside when respiratory is there and get information about who's going to look what, who's going to move the devices around, and what can the nurse do comfortably so that she doesn't have to worry about injuring the patient's airway. I can't say enough about working as partners. And then other kinds of risks too, remember to look at the whole patient. So we're talking about pressure risk on the skin, but is that patient awake? And do they have physical sensation? Because they can let us know then if something's happening that's untoward. The same thing with looking at other factors like moisture or edema. A lot of patients do a lot of swelling when they're very ill, and that there again puts the skin at much better risk. So I think being really aware of the patient as a whole and making our assessment for skin risk is so important. Critical care, there probably aren't enough pieces of paper for me to find out all the things that are at risk that can cause risk for device-related pressure injury. These are the ones I just thought of the top of my head. There are lines everywhere. We know that on a patient in ICU. They've got rectal tubes, blood pressure cuffs, arterial lines everywhere. And this prone patient, I'll talk about a little bit more in just a minute. But just remember, all of those things are important because in the wrong place, they can cause pressure injury. Too tight of a blood pressure cuff or a Foley catheter laying under somebody's thigh, all of that can cause pressure tissue injury. And then in general, one of our sister hospitals, when they've decided to do their morning huddles to talk about who's at risk or has early pressure injury, they're actually counting devices so that they know specifically, say that Mrs. Nelson has 12 devices that increase her risk for pressure injury. So proning has been around before COVID, but it's important to bring that up now especially. But I remember when we were first proning patients to help them, to help aerate the lungs better, and I would get called to the ICU because they'd turn these patients off their prone position and their whole chest would be sheared off. So they would have lost basically all their epidermis. And so now there's lots of ways we look at trying to prevent this. I just read another article last week that was comparing either doing some offloading with pillow positioners versus doing a mattress, an air mattress that was safe, and using silicone foam dressings that would protect the skin from moisture and shear, thus decreasing the risk for pressure. And proning for COVID has become very common. When people get very ill, they often do it for awake, non-intubated patients too. It doesn't matter whether the patient is awake necessarily, because we still are responsible to be asking and checking about that skin and preventing pressure injury. This is a good article if you're interested in that for more information. The cost is astronomical. Agency for Healthcare and Research talks about $9 to $11 billion per year for our pressure injury costs. And anywhere I've seen many sites say it is at least $10,000 to $20,000 per person. Now that's not a very small stage 2, but a significant ulcer does cost quite a bit of money because they don't heal well. Generally, they happen on people with comorbidities, and so the healing takes a long time, thus requiring a lot of money. Pediatrics, again, our second speaker is much more attuned into this, but for nursing, it's so important. This is a great article reference. Kids don't have a lot of skin and preemies. We can't afford to lose that. So much of this is preventable, and nursing needs to be very attuned into where they can do prevention rather than try to catch up later after pressure injury has happened. And again, moisture, I just want to remind people to keep that makes such a big difference in changing the risk for the skin to break open. Using barrier ointments and other kinds of cleansing things really help keep that skin healthy so we can decrease that risk. And then in summary, I just want to say when I was working with one of the hospitals in Minnesota, at least 12 years ago, we started reporting device-related pressure injuries to the health department if they happened in our facilities. And the first time we reported them, it went up to 30% of our reportables. We were surprised. We knew they happened. We didn't know they happened that much. So it's one of the things that when you're looking at pressure prevention now, device has to be right up there in the front of what we're looking at. The other thing this website will show you if you're interested is lots of other teaching tools that you can put in your toolbox, much like the National Pressure Advisory Panel looks at, but things that are helpful in trying to put in your bundles for prevention. So this is the end of my talk. I want to thank you for your attention. There'll be some time for questions later, and I will turn this over now to Denise.
Hi, thanks for the introduction. Today's objectives are to identify respiratory device-related pressure injury bundle elements, to discuss how patient mask leak is related to mask strap tension and to pressure injuries, as well as to discuss the relationship of the Braden QD scale and sleep mask-related pressure injuries. So I want to thank Vicki for a great review of pressure injuries. In this section, we're going to talk about respiratory device-related pressure injuries. And since the addition of patient repositioning and moisture management and bed surface, the number of pressure injuries that we referred to historically as bed sores have been significantly reduced. And the number of device-related pressure injuries is on the rise. So when looking at the types of devices causing pressure injuries, respiratory devices are at the top of that list. Through a combination of skincare bundle changes, BiPAP mask, patient mask leak guidelines, compliance audits, increasing active surveillance, and including RTs on the SWAT and the Skin Integrity Task Force, we were able to make a significant change in our high-stage pressure injuries at Rady Children's. In fact, it was so significant that the devices are no longer the #1 cause of pressure injuries at our facility anymore. And BiPAP masks, which were our #1, have dropped and aren't even on our parade charts anymore. We still have a little bit more room for improvement in our NICU when we're having a combination of nasal CPAP prongs and the NG in the same nair. And those are the last two blips that you see on the scale there. It is important to catch more than just the number of pressure injuries, so we use a denominator to account for the population that have acquired the condition. In pressure injuries, normally we use patient days, and this allows us to see what the rate of pressure injury is amongst our patients, even though the number of patients may vary. Patient days is most frequently used for our hospital-acquired conditions. Although if you are specifically looking for BiPAP injuries, you can use the number of non-invasive ventilation days as your denominator for a more accurate comparison. I would still collect the number of patient days as well, since this is the ratio that you're going to use to compare yourself to other facilities. The Institute for Healthcare Improvement promotes a bundle approach to pressure ulcer prevention. A bundle is a set of very straightforward practices, some really simple interventions that when combined can lead to a positive patient outcome. The power of the bundle lies in an all-or-nothing approach. To achieve desired results, caregivers have to complete all parts of the bundle. And if you miss any of the bundle interventions, then you're putting your patient at risk. And so we consider that as non-compliant for the bundle. For critical care patients, the National Pressure Injury Advisory Panel includes proper fit, cushioning, inspection of the skin, rotation and repositioning of devices, education of staff, and awareness of edema, as well as avoidance of placement on the site that is injured or previously injured as best practices. Medical devices are the #1 cause of pressure injuries in children, and the one that usually causes it in them is CPAP masks and prongs. Tracheostomy tubes and oxygen sat probes also lead the way. As you can see from this slide, from the National Pressure Injury Best Practices for pediatric populations, they choose repositioning devices, rotating devices, cushioning the skin, education of staff, awareness of edema, and proper fit as the bundle elements in pediatrics. The Children's Solution for Patient Safety Data Coalition did a literature review, and based on their near-grade classification levels, they recommend the following bundle elements for skin pressure injury protection in pediatrics: skin assessment, device rotation, patient positioning, appropriate bed surface, and moisture management. But there's still a lot more room for evidence on this subject. The Solutions for Patient Safety Data Coalition chose the skin assessment and device rotation or offloading of pressure as their mandatory elements to prevent pressure injury. In addition, they also recommend cushioning of devices and proper fit as recommended ones. At Radies, we chose to incorporate all aspects of the mandatory and recommended respiratory device bundle at our facility. Since we know that skin injury can occur within 6 hours and sometimes even 3 hours of constant pressure on the skin, skin assessment under and around the device should occur a minimum of every 6 hours, but with a recommended of every 4 hours. The 6 hours we gave as a recommended for extremely low birth infants because it coincides with their touch times. So this would include any patient on non-invasive ventilation or CPAP, whether they're on BiPAP mask or CPAP or nasal pillows, Fisher and Paykel prongs, or RAM and OptiFlow. Any patient on a high-flow interface, such as a RAM or OptiFlow, OptiFlow Junior, or Fisher and Paykel high-flow cannula. Any patients with invasive airways, such as an oral or nasal ET tube or tracheostomy tube. The only exception to the every 4 hours rule is the elbow kids for every 6, and a standard nasal cannula, which we check every 12 hours. We also cushion and protect the skin with some sort of foam padding under the respiratory device. And foam padding is considered a pressure barrier versus, say, a hydrocolloid, which is a skin barrier but not a pressure barrier. We do require it for anybody who's on CPAP or BiPAP mask for more than 8 hours a night, unless they're using their home mask less than 8 hours and they're on their home settings, because that increased pressure of the BiPAP can cause increased pressure against the skin. With our trachs, we use foam under the trach flange, and in an acute postoperative period for a fresh trach, we're going to use gauze or leave the skin bare due to the sutures. With endotracheal tubes, we use the securing device as needed or tape. We also, for the nasal cannulas, we require some form of foam barrier under the nasal cannula on the cheeks if they're less than 1 kilogram. Although I'll tell you that all of the nurses in the NICU put it on the baby, so that's fine. All other patients should only have it under the tubing when needed to protect their skin. So it's already starting to get red. And with our CPAP and BiPAP masks, we do rotate them between different devices so that you have different skin contact areas and different pressure points. And we alternate them to redistribute the pressure. If it's not possible to alternate them, we do require that the mask be taken off to give a relief of pressure, and that we wash the mask and the face and dry it, and we use baby soap for that. We also use a blue Velcro with a clip on it to offload pressure of the tubing and connectors as needed, so they're not putting additional pressure on the mask. For trach offloading of pressure, we make sure we use something to hold the trach tubing up so it's not pulling, and we reposition the patient's head and neck to minimize pressure. Also, with an endotracheal tube, offloading of pressure of the ventilator circuit to minimize pressure from pulling on the lip and the gum. And we're going to discuss what proper fit is in the next slide. So proper fit is the newest recommended bundle element, and I think it's where we made the majority of our changes in our bundle element at Rades. But we first needed a definition to understand how we could be compliant with this. So the definition of a fit or a thing of suitable quality, standard, or type to meet the required purpose is what proper fit means. The functional definition of it is of or having a special activity, purpose, or task relating to the way in which something works or operates. So utilization of that term, proper fit, within the constraints of respiratory devices needed to be confined qualitatively by the definitions of both fit and function. So that definition would be following the guidelines of the manufacturer for sizing of the device, with the following functioning conditions met for devices providing higher levels of support. So the sizing of the respiratory device meets the demand that's set forth in the patient's order. So assessment for proper fit of respiratory devices assigned specifically to CPAP and BiPAP is that first we size it based on manufacturer's recommendation, but then the mask should be adjusted to maintain the PIP and PEEP that are set, but allowing for a leak. So you're going to adjust the mask strap tension to maintain a 25 to 55 patient mask leak. But that's only in devices that can measure patient mask leak, such as the V60. When you're using a Fisher and Paykel mask and prongs, we're going to go according to manufacturer recommendations for 100% occlusion of the nair, and it should maintain the CPAP or the pressures that you want that are ordered. With trachs, it's assessment that the trach ties are secure and not too tight by the ability to fit one finger between the neck and the ties and collars, not two fingers, just one. ET tube is the assessment that tension from the ventilator circuit to the endotracheal tube is minimized. It does not mean that it's the right size endotracheal tube for the patient. And with RAM cannulas, which we refer to as a nasal cannula attached to a ventilator, so a nasal cannula vent, we should maintain the PIP, the CPAP, the flow with the manufacturer recommendation of between 60 to 80% occlusion while allowing for a leak for exhalation if the patient's mouth is closed for carbon dioxide removal. When used in conjunction with a ventilator for non-invasive mechanical ventilation or for CPAP, proper fit will allow for an 80% occlusion with pressures 2 to 3 centimeters below what is recommended or written for. And then we set about a 20% leak around the device to make sure that the patient can get rid of their carbon dioxide. If you're using these devices as a high flow nasal cannula, then the manufacturer recommends a 50% occlusion while allowing for a leak. Making sure also that the tubing and connectors don't appear too tight and there's no connections between the bed and the patient. With the OptiFlow and the OptiFlow Junior, it's 50% occlusion of the nairs. And with a nasal cannula, you want to make sure that you're assessing for best fit for the patient and that the tubing connections do not appear too tight. So most nasal cannulas are about 40 to 50% occlusion of the nair. Now we're going to talk a little bit about patient mask leak. This is a parameter measured in liters per minute of the amount of flow that comes out between the non-invasive ventilation mask and the patient's skin. This amount of unintentional leak is affected by the tension that you apply to the straps that secure the headgear, and they hold the mask in place. The more tension that you apply to those straps, the tighter the mask is on the face, and the smaller the patient mask leak will be, putting increased contact pressure on the skin. While if you use less tension on the straps, it can cause a loose fit, which can also lead to friction or shear from rubbing of the mask on the skin. And you add that to moisture from their saliva, and you've got a pressure injury. So Accorda et al. Recognized the possibility of patient mask leak impacting their study and utilized an air leak guideline that identified less than 6 liters per minute as too tight and greater than 60 liters per minute as needing caution with use. Squires and Hinman suggest to tighten the head strap gear slowly if needed to minimize but not get rid of the leak. Lauterbach et al. Identified high patient mask leaks of greater than 55 liters per minute as the sole contributing factor that correlated significantly with non-invasive ventilation mask-related pressure injuries. And we also discovered the fewest pressure injuries occurred when you used a range of 25 to 55 liters per minute as a mask leak range. After that, we implemented a quality improvement project using a hospital-wide patient mask leak range of 25 to 55 liters per minute to reduce non-invasive ventilation injuries within our hospital. In this QI project, we addressed the clinical question: in pediatric patients wearing masks during non-invasive ventilation, does using a mask leak range of 25 to 55 liters per minute lead to less pressure injuries over current practice of not using any range? So per hospital standard practice, we were utilizing foam barriers, device rotation, skin assessment, and offloading of pressure bundle practices prior to this intervention. And the same practices were made throughout the project, so nothing was changed there. We divided our project into phases. We had a pre-intervention phase, education phase, and a post-intervention phase. During the pre-intervention phase, we had 6 subjects, or 5.2%, who incurred a pressure injury at a rate of 0.51 per 100 non-invasive days, or 0.26 per 1,000 patient days. Of the 1,932 non-invasive ventilation days since our education was completed, only 1 subject incurred a high-stage pressure injury. So that's a 0.05 out of 100 non-invasive days, or a 96.79% reduction in pressure injuries, or 0.05 out of 1,000 patient days, which is a 92.86% reduction in pressure injuries per patient day. The findings from our project revealed that maintaining greater than 90% compliance with a pediatric NIV mask leak between 25 to 55 liters per minute resulted in 0 mask-related pressure injuries of any stage since December of 2019. Since then, we have found a drop in compliance with this measure can lead to pressure injuries. They just haven't been high stage. They've been stage 1 or 2. So future prospective studies should aim to assess this strategy in the adult population as well, as the data should be similar in adults. This is our skin integrity product guide. It provides the devices that we use at our facility, the skin barrier or device securement device or product that we're using, how to use it, and the required assessment and documentation. For nasal CPAP prongs and mask, we require 100% occlusion per manufacturer recommendation, skin assessment every 4 to 6 hours, and the use of Mepilex transfer to pad the device. That's our foam barrier. For the Optiflow Junior, the Wiggle Pad and Wiggle Wings Velcro acts as the pressure barrier. And for the Optiflow Adult, I like to call it Optiflow Senior, we use the securement device that comes with it, and we don't strap it too tightly. All of our nasal cannulas, regular heated or high flow nasal cannulas or regular nasal cannulas attached to the vent, are secured either with Mepilex transfer under the tubing or on the cheeks with tender grips. For BiPAP masks, we use Mepilex transfer or Mepilex border and ensure that the position strap of the headgear is not putting pressure on the back of the ears, the neck, or the cheeks. For nasal pillows, you use the securement straps included with the device, but don't strap them too tight. We are in the process of changing our polymem for Mepilex Silver under the trachs for the first 5 weeks after a new tracheostomy, hoping to diminish the amount of granulation tissue we are seeing with the polymem, which we feel is related to moisture retention in that area. We do recommend Draw-Tex if there is a lot of secretions. I also wanted to go over just a little bit about the Sensicare and the Cavalon nose sting barrier. So we can use Sensicare adhesive remover, and we do utilize that. Now, if you're going to use the Cavalon nose sting barrier, you can utilize that, but you have to wait and make sure that it is completely dry before you put anything on top of it. Otherwise, it acts as an additional adhesive. So what the Cavalon nose sting barrier does is it provides a barrier over the skin that acts like an additional layer of skin. So if you were to take tape off of it, provided it was dry when you applied, you would really just be removing the nose sting barrier and not the cells of the skin. So it can be of benefit to you with your respiratory device. This EPIC documentation bundle is currently located at the bottom of the RT patient assessment flow sheet in EPIC for ease of documentation. It has its own flow sheet page as well, so it can be added to the nursing assessment page with a question such as patient on a respiratory interface, yes or no, that would allow it to drop in at that point. This makes for easy collection of data with the bundle over a 24-hour period to assess your compliance. If skin is not within defined limits, then there are multiple options, none of which are staging. Only a wound and ostomy care nurse or someone trained in staging can stage a wound, such as a wound treatment associate. The first choice that is available is blanchable redness. This is not a pressure injury. This is an indication that there is some irritation to the skin, which could lead to pressure injury. If it is anything other than within defined limits, then the RT or non-blanchable redness, within defined limits or non-blanchable redness, then the respiratory therapist and the nurse have to document the location of each abnormal finding and report it to their leadership, take a photo, order a wound consult, and notify the provider. This ensures that the wound and ostomy care nurse can stage the wound from the first sighting of the injury. Respiratory therapy should be represented on the organization's pressure injury prevention team. Sample activities of what this type of team might do is develop and implement organizational-wide policies and processes to prevent respiratory device-related pressure injuries. Education and training of respiratory therapy staff in best practice for respiratory device-related pressure injury and documentation. Auditing of respiratory therapy compliance, consideration of skin care and review of new respiratory device purchases, development of processes for shared documentation or collaboration during reports between nursing and respiratory therapy staff using common terminology, as well as partnering with wound care and respiratory staff during grand rounds to provide education on identification and prevention of pressure injury, which is kind of what we're doing here today. So active surveillance is the periodic head-to-toe skin assessment of every patient in a particular unit or every patient who's scoring high risk by a team, including at least one wound and ostomy care nurse or certified wound treatment associate, a bedside nurse, and a unit PI nurse champion. If the patient is using a respiratory device, a respiratory therapist should be involved in the rounding on this patient. Having the RT on the team allows for the removal of the respiratory device for a quality skin inspection while maintaining the PEEP needed for the patient to avoid decompensation. Active surveillance's close attention to the skin allows time for education of the staff on the bundle elements, ensures the bundle elements are all being met, and allows for early identification of pressure injuries as well as intervention prior to those escalating to high-stage pressure injuries. Having a respiratory therapist on the team also allows for close attention to all of the different standard bundle elements. A wound and ostomy care nurse is a registered nurse who has been formally trained to provide care for stomas, wounds, fistulas, drains, pressure injuries, and/or continence disorders. Looking at a person's skin from head to toe is an important nursing function, and certainly nurses document this on a patient's admission, but not too often after admission. Usually it is another interdisciplinary team member that might notice the change in the skin. Respiratory therapists, nurses' aides, physical therapy may notice, but there might not be good communication between disciplines or training of that interdisciplinary team so that they understand the significance of what they're seeing. To do a good skin assessment, you actually have to touch the person. Things such as turgor and temperature and moisture involve physical contact with the skin. You can do some visual inspection that could include color and cyanosis, jaundice, or modeling. So skin wound assessment teams usually meet monthly or quarterly and are involved in doing prevalence studies at their facility. They review new literature and the evidence, and they review their pressure injury rates, and they make modifications of the policy and procedures based on that evidence. Pressure injury risk assessment tools, which Vicki mentioned a little bit earlier about the Braden, were created to predict patients at risk for developing pressure injuries, or at higher risk, because all patients with respiratory devices are at risk. But it is essential that those tools perform well, and they have to offer good specificity and sensitivity. Tools that can accurately predict a high risk for pressure injuries and potentially direct more aggressive or more frequent interventions to prevent pressure injury from occurring. The most frequently utilized ones are the Braden Q, the Garvin, and the Glamorgan scales. Anthony et al. Reported that the Glamorgan scale was the most valid of these scales in pediatrics, but did not specifically test it for respiratory device-related pressure injuries. The Braden Q score, developed by Quigley and Curley, is widely used in the United States in adults and pediatrics, but initially the predictive validity testing of the Braden Q only included immobility-related pressure injuries in critically ill patients. The Lauterbach et al. Previously identified that the Braden Q score did not identify with pressure injuries in patients wearing non-invasive ventilation masks, and in 2018, a new scale, the Braden QD, was developed, which the D stands for devices, and it was found to reliably predict both immobility-related and device-related pressure injuries in the pediatric acute care environment. The Braden QD scale, similar to the Braden Q scale, has 7 subscales. The new scale includes mobility, sensory perception, friction and shear, nutrition, and tissue perfusion and oxygenation, while replacing moisture and activity from the Braden Q scale with the number of devices that are on or transversing the patient's skin or mucous membranes and the ability to reposition those. This new scale has been tested on patients who are premature to 21 years of age, including cardiac patients, and was found to be valid and reliable. The Braden QD dichotomizes the scores into an at-risk or no-risk categories and identifies patients with a score of greater than 13 as being at risk for hospital device-related pressure injuries. We completed a retrospective chart review of all the pediatric patients with NIV-related mask injuries. Demographics and Braden-Q-D scores were extracted from the electronic health record. The scores were dichotomized into no risk and at-risk scores ranged on the basis of each scale scoring parameters. The McNamara test was used to assess whether the Braden-Q and the Braden-QD had the same level of classification. While the Braden-QD did correlate with respiratory mask-related pressure injuries at all times collected, the Braden-Q did not. There were no significant changes found amongst the groups in relationship to age or to gender. So what do you need to know about this? You need to know that the Braden-QD score for all of your patients who are on non-invasive ventilation. If the pediatric patient's Braden-QD score is greater than or equal to 16, which is the higher risk category, then we should be ensuring that all bundle requirements are met and monitoring those patients very carefully. The Braden-QD score has not been tested in an adult facility yet, but that is going to come. So why do we require all of these steps that you see on the screen? To get it entered into a safety report and to ensure the accuracy of our data for reporting out. If staff even do one of these things, the leader, charge, or wound nurse or provider makes sure that the safety report is written, and the person reviewing the safety report ensures that all of these steps are completed. So bundle elements are important in the prevention of pressure injuries, but the entire bundle must be followed. Maintaining a patient mask leak between 25 to 55 liters per minute can reduce the rate and number of all-stage pressure injuries. The Braden-QD correlated with sleep mask pressure injury when the Braden-Q did not. Staff caring for patients with CPAP and BiPAP masks should be aware of the Braden-QD, which may indicate a need for more frequent inspection, rotation, and protection. And we do include that in our report on our patients now who are on BiPAP. And RTs need to be more actively involved in the respiratory device-related pressure injury prevention. That concludes the presentation. And before we get to your questions, Lexi will tell everyone how to obtain continuing education units.
Thank you, Vicki and Denise, for that very informative presentation. I will now tell everyone how they can obtain their CEs for this presentation. This educational activity is approved for one contact hour. To obtain CE credits, go to www.saxtesting.com. You will need to register at this site. Complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Support for this educational activity has been provided by Philips. An archive on-demand version will be available on betteroutcomes.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. Now we have time for some questions from our participants. First of all, we have a question from Josie. What are the best tools to enhance collaboration between nurses and respiratory therapists? Denise, would you like to take that question?
Sure, I'll take that question. I thought Vicki was taking it because I saw her move, so I was waiting. But to get collaboration between nursing and respiratory therapists, I think it's really important. Most hospitals have a pressure injury prevention group. They might call it SKIN, they may call it SWAT. To have RTs actively involved and to have their leadership supporting them as that's the type of project that they're involved in. I think that that's really important. Getting them involved in any wound or SWAT teams or anything. That's really how I became involved in it. I was asked by my supervisor to be on a SKIN team, and so I joined it and then realized, what a big issue we actually had. And so I started working on it.
Thank you.
I will
Vicki, do you
just
have anything to add to that?
Yeah, I mean, I agree with everything that's been said. And we unfortunately started this after an incident happened, and then everybody had to come to the event, process recording. But what came out of that was quality spearheaded then, that there would always be somebody from these other disciplines on our pressure ulcer teams. And that way people continued to learn from each other. And we did interdisciplinary education. I would teach for the respiratory therapy staff, they would teach for the nursing staff, and everybody put it together. We did some conference kinds of poster kind of things because it was really early on, and we found that people were much more excited to do it. So I think you have to kind of include everybody in your pressure teams, and I think you have to include education for both departments. I don't know if there's any magic to getting that to happen, but I would hope you don't have to wait till something untoward happens like we did a long time ago, because it seems to be now that if your bundles are written, like we talked about so much here, Denise did such a good job. If you have bundle care that shows who's going to do what, then you almost have to work together, because who moves the device, who looks at the device, who stages the skin. And so I think that's the other thing, is to write a really good bundle.
Thank you. We have another question here. Either one of you might want to take this. What would you recommend as routine barrier ointment to the nose or face for patients using a CPAP or a BiPAP mask?
We don't recommend any ointment or anything routinely for prevention. We do use Medi-Honey if the patient already has an injury, but we also remove the device from that area. Any type of ointment is going to be a little bit oily, and it's going to cause friction in that area if there's a device on top of it.
I would second that. I think what we used is more what Denise talked about. We might use a no-sting skin prep and let that dry for prevention, but we would rarely use an ointment itself. But the idea is still for barrier.
Great, thank you. This is another question about CPAP masks. Some facilities are using cotton balls on CPAP masks. Is there a preference to use a foam barrier or a foam device rather than cotton ball?
So I will reiterate that a foam barrier is a pressure barrier, because it provides some relief of the pressure that you're applying to the mask against the skin, because it's foam, so it has a little bit of give. Cotton balls do not. So cotton balls might be a skin barrier. I've never heard of cotton balls. They might be technically a skin barrier, but they're not a pressure barrier, so they're not going to help prevent pressure injuries.
Great, thank you. At either one of your facilities, how often have you seen RTs documenting on the skin assessment sheets?
So the RTs document on our skin assessment form, which is at the bottom of their respiratory assessment sheet. So we actually included it in the respiratory assessment, document on skin, and they have to document on all aspects of the bundle every 4 hours, and I audit it weekly. So I will say they do it all the time, because we're at 99% compliance, because if not, they get an email from me.
This is a question that might be more for Vicki, but this is about mucosal breakdown and injury related to ET tubes. Do you have any recommendation on ET tubes?
Well, what we saw on adults, obviously, and true mucosal injury isn't pressure injury. It really, the mucosa itself, but it's still important. And I think again, I think Denise spoke to that, but really the inspection and the rotation of the tube a little bit is all that you can really do, because it's important, obviously, that you have them there, but it's really about inspection and rotation. I don't know about with peds if you have anything else that, I think she covered that also, but anything else, Denise?
No, in peds it's the same, inspection and rotation. So, we're not going to untape the tube off of their skin if the tape is secure to rotate the device, but the next time it needs to be retaped, it gets moved, and we do document where in the mouth it is taped at so that people can document their rotation of the devices. We don't have a lot of mucosal injury from endotracheal tubes. We sometimes get it from nasal CPAP prongs in the NICU.
Great. This is a question, again, dealing with the NICU and prongs. And this would be an interdisciplinary issue. And do you have any recommendations on how to get between the RTs and the nurses to come to an agreement on how tight the prongs should be placed? Obviously, you can see the pressures on when they're on certain modes, but what is your recommendation for when they're just on prongs?
We actually just recently had this issue about a year ago because Rady has a main satellite, and then it has a main hospital, and then it has satellite nurseries. So we have 3 level 3 satellite nurseries, and we did find that there was some issues between, like, the RT resizing the prongs to 100% occlusion. The nurse felt that it was too big, so she put in smaller prongs, which were pinching the septum. We get pressure injuries. So we actually created a skin integrity task force of nurses, respiratory therapists, physicians, and nurse practitioners. And we sat down and we discussed best practice. We talked about all of the things we had implemented at Rady Main. And then we now have what we refer to as skin champions: 1 physician, 1 nurse practitioner, 2 day shift nurses, 2 night shift nurses, and 2 day shift RTs and 2 night shift RTs, who are all superbly trained in what is appropriate. And then when I showed those previous slides of what to use, when to use it, how, that's where that came from. So we started that so that if somebody tries to say, no, that's not, I got this more recent email, I got this, they can say, this is it, Denise updates this is the last updated date, this is what we're supposed to do. So that's how we resolve that. We actually have another meeting in a month because some people are starting to slip again. So we just follow through with more education.
Great. And I think we have time for just maybe one more question here, and maybe both of you can jump in on this. And how do you recommend getting involved in research for pressure injuries?
Well, I think both of us have been involved in some research. And so I think when you have people on done it, I think sharing that kind of information with staff, whether it be in sort of like journal club or bag lunches, sharing that information, I think, does engage people and that it's at the base of what we need to do, good research, not just good opinion.
My suggestion would be to go to your leadership team or to interdisciplinary councils. So many hospitals have interdisciplinary councils, which RTs are not usually aware of for some reason. I'm not sure why, but most of them have them, and a lot of hospitals have a research and evidence-based practice council. So I would find out if your facility has one. If so, they can mentor you through the process. If they don't, then you can go to your leadership team, explain what you want to do, and they usually have a chief nursing officer, someone that they can go to, and you can get budgeted for it. You can do a cost analysis, and usually if it's for prevention of pressure injuries, the hospital will support you because they are very costly.
Thank you very much. Okay, we're out of time for questions now. Thank you for everyone who asked questions. I will now turn over the presentation to Monica for concluding remarks.
Thank you so much, and thank you for your expertise, and thank you for your participation. This does conclude our webinar for today. I would like to remind the audience that there is a survey for you at the conclusion that will pop up immediately, and we would greatly appreciate you sharing your opinions on today's webinar. Thank you again, and on behalf of our presenters, SACS Healthcare Communications, and our sponsor, Philips, we hope you enjoy the rest of your day.